Welcome to The Explainer. Today, we're going to walk through a clinical case that, trust me, you are absolutely going to see in your practice, a patient with newly discovered high blood pressure. We're going to break down the diagnosis and management step by step.
So, let's set the scene. Your patient walks in. He's a 58-year-old guy, just here for a routine checkup. He says he feels mostly fine, but does mention some occasional mild headaches. Nothing else major. This is a super common, everyday kind of presentation.
Okay, so let's break down the workup. First things first, that blood pressure. Whoa, 152/94. And on the recheck, it's still high at 148/92. That's our big red flag. But then you look at the rest of the picture, right? A BMI of 29, that's creeping up there. He's got a desk job, smokes about half a pack a day, and admits to a high-salt diet. It's like all the classic risk factors are just lining up. The labs for now look okay, but this whole story is painting a very clear picture.
Okay, we've got the numbers, we've got the context. So what do we actually call this? How do we formally classify it? This is where we need to stop guessing and go straight to the official guidelines to make a proper diagnosis.
And here they are, the JNC7 guidelines. This chart right here, it's your best friend because it takes all the guesswork out of it. You just find where your patient's numbers land. So his systolic is consistently in that 140s range, and his diastolic is hanging out in the low 90s. It's pretty clear when you see it laid out like this.
And boom, there it is. A systolic reading between 140 and 159, or a diastolic between 90 and 99. That puts him squarely in the category of stage 1 hypertension. No ambiguity here. The numbers really do speak for themselves.
All right, we've got our diagnosis, stage 1 hypertension. So now what? What's the game plan? Well, it's really a two-part strategy, and it's so important that we start with the foundation before we even think about pulling out the prescription pad. Look, before we talk about a single pill, we have to talk about lifestyle. This is non-negotiable, and it's our first best tool. We're talking about getting that BMI down through weight reduction, swapping out that high-salt diet for something like the DASH plan, getting him moving to counteract that desk job, and this is a huge one, smoking cessation. Each one of these changes can make a massive difference in his long-term risk.
But let's be realistic. For stage 1 hypertension, lifestyle changes are usually just part of the plan. We're probably going to need meds. So, what's the thinking here? What's the actual philosophy behind choosing a drug? It's not just about picking one off a list. What's the smartest and safest way to get his blood pressure down?
And this right here, this quote really sums up the modern approach to hypertension. The whole idea is this: using low doses of two drugs that work in different ways gives you better blood pressure control with the fewest side effects. It's about being smart and strategic, not just aggressive.
Let's put these two strategies head to head. You've got the old school way, high-dose monotherapy. You just keep cranking up the dose of one drug. The problem? You're also cranking up the risk of dose-dependent side effects, the things that make patients feel crummy and, stop taking their meds. But then you have the smarter approach, low-dose combination therapy. You use two different drugs at lower doses. And what happens? You get better BP control and fewer side effects. It's a win-win. You get the benefit without the baggage for the patient.
Okay, so we've got our guiding principle. A low-dose combination approach is the way to go. So for our 58-year-old guy, what specific drug are we going to start with? Let's make the choice.
So we pull up a table like this one. This is our roadmap. Find stage 1 hypertension over on the left. Now, our patient doesn't have any other big issues going on. No heart failure, no diabetes, what we call compelling indications. Since he has none, we just follow that row all the way across to the column that says initial drug therapy without compelling indication.
And there you have it. The guidelines point us straight to a thiazide-type diuretic as a top option. Why? Because they're proven, they're effective, and they're affordable. Sure, you see other options there like ACE inhibitors or calcium channel blockers, and those are great too, but a thiazide is a fantastic place to start for a straightforward case like this one. So here's what the actual prescription looks like. We're going to start him on hydrochlorothiazide, or HCTZ for short. And notice the dose, just 12.5 milligrams. Super low, right? We're starting low and slow. And the instructions are key too. 1 tablet in the morning. We do that because blood pressure naturally tends to spike in the morning, so this helps blunt that effect right when he needs it most.
Okay, let's pull back from this specific patient for a second. What are the big picture lessons here? What are the core principles you can take with you to apply to pretty much any patient with new hypertension?
Okay, if you remember nothing else, remember this. 1. Start with the lowest dose possible.
You want to bring the BP down gently. 2. If one drug isn't cutting it, your first thought shouldn't be to max out the dose. Your first thought should be to add a second, low-dose drug. That's our combination principle. 3. Make sure those two drugs work in different ways for a nice synergistic effect. 4. Whenever you can, use once-a-day meds. It's just so much easier for patients to stick with. And finally, number 5, you have to talk to your patient. Education about their lifestyle and their meds is absolutely critical for this to work.
And I'll leave you with this final thought. We've written the prescription, and that's important. But remember, pharmacology is just one tool in the toolbox. For this guy, a 58-year-old smoker with a desk job and a taste for salt, which of those lifestyle changes is going to be the real game changer for his long-term health? Think about it, because that's where you go from just treating numbers to actually caring for a person. Thanks for joining us.